Hey, my name is Kari Collins. I'm going to tell you a little bit about myself and also talk a little bit about this webinar and let my colleague, Michelle Kilgore, introduce herself also. I'm a licensed clinical social worker, and I've spent about 20 years as Director of Child and Family Services at a community mental health center in Southeast Kentucky, where I also provided both mental health and substance abuse services. I was also a project director of a system of care grant in Southeast Kentucky and also participated as an implementer on the state level with 2 other system of care grants. I'm a former director of one of the original Reclaiming Futures sites that was funded originally by the Robert Wood Johnson Foundation, and I'm right now a current Reclaiming Futures coach and consultant with the National Program Office at the Portland State University. And also at the state level, I served as the project director and evaluator for a SAC grant, a System of Care Adolescent grant, and a co-PI for a CSAT grant called the SATED grant for substance abuse treatment dissemination. Michelle, do you want to talk a little bit about what you've been up to?
Yes, I guess I say good afternoon, everyone. I guess everybody's all across the nation, so it's all different times.
Yeah.
I'm Michelle Kilgore, and I have, as with Kari, about 17, 18 years of clinical experience working with youth and their families who've had mental health and substance abuse issues. I also served as a program coordinator for Reclaiming Futures site here in Southeast Kentucky, and also served as a coach for another site that we had here in Kentucky with Reclaiming Futures. Currently, I work for the Department of Behavioral Health in the state as a program administrator for adolescent substance abuse and co-occurring treatment. And through that position, I serve as the statewide youth coordinator through NASADAD, which is a National Association of Substance Abuse Directors. And they have different levels. They'll have a women's treatment coordinator and different parts out of the state. And so I serve as the statewide youth one. And then right now, currently, I'm the project director with the CSAT grant that Kari mentioned, the SATED grant, which is a state adolescent substance abuse treatment enhancement and dissemination grant that's specifically for substance abuse but also co-occurring.
Thank you, Michelle. We're going to get started today with a few surveys that we want to do. The first couple of surveys are really about getting to know who's on the webinar, and so that you all know also who's on the webinar. So Kay, if you wouldn't mind pulling up the first survey. You can see this survey is about system care partners. And what we're really wanting to know today is who you're representing within the system of care. What partnership are you representing today? If you just go ahead and click on the one, we realize that some people may be in groups, so please click on all of them that apply if you're in a group or if you happen to be wearing many hats. Looks like we've got a number of folks from juvenile justice and from mental health treatment or promotion, also substance abuse treatment. Excellent. And child welfare is represented, and education is there, and citizens or community folks are there. Let's go ahead, Kay, if you don't mind, pull up the next survey. She's pulling up is also one to get to know better who you are. And here we're actually going to be asking you about the roles that you're representing today. So as best you can describe the role that you're assuming. And once again, if you're in a group, please check all that apply. If you're wearing multiple hats today, please check all that apply. like we're all over the board today. Excellent. This is great. Looks like we have a really good representation of folks across the board today. So let's move on to look at a definition. I say that because, you know, we probably could come up with all sorts of discussion, maybe a whole webinar on this, but for the purposes of today, we're going to be talking about youth who have a disorder, both substance use and mental health. It's sometimes referred to also as a dual diagnosis disorder, but oftentimes they have multiple diagnoses as well. What I want you to do with this, and I'm going to just go ahead here and read this out loud to you, if you wouldn't mind indulging me with this. I promise not to do it for all of them. But I want you just to be thinking about this as I'm reading these, of whether or not this is a symptom of a substance use disorder or a mental health disorder. Sudden changes in personality without another known cause. Loss of interest in one's favorite hobbies, sports, or other activities. Sudden decline in performance or attendance at school or work. Changes in friends and reluctance to talk to new friends. Deterioration of personal grooming habits. Difficulty in paying attention, forgetfulness. Sudden aggressive behavior, irritability, nervousness, or giddiness. Increased secretiveness, heightened sensitivity to inquiry. Hanging out in strange places like alleys, garages, barns. A change in sleeping and eating behaviors. Okay, could you pull up the next survey, please? This next survey is a real simple one to answer, and whatever you think is most appropriate here. Were those symptoms that I just mentioned, symptoms of mental health disorders or substance use disorders, or both? 100%. Boy, you guys are good. You're quick. And interesting enough, when I took this information, when I was looking at information, this slide was actually written for a substance use disorder presentation, and it struck me because when we were reading it, especially in light of our kids that we serve, that really those are absolutely the same, regardless. So thank you, Kay. So the question for us here really is, which came first, the chicken or the egg? The mental health or the substance use disorder, we always feel like we have to kind of ferret that out. So it's important for us to know in order to treat successfully, right? This is a debate that's been going on for decades, and some systems of care have a real clear philosophy or supporting process that kind of deems what the services are provided and in what way they're provided. Some systems of care are actually in flux right now and are trying to change their process as our healthcare system changes across the United States. Kay, could you pull up survey number 4, please? I promise there's no more surveys after this for a while. So what we want to know is which came first, the chicken or the egg? And the question for this survey really is about right now. Not where you go and not where you were, but right now. Answer this to the best of your ability, and 100%. So, we got some more. Good, we've got some other people in the room here. So what we're looking at is right now, which best describes your community. So at this point, we're looking at about 75% of you, 77% of you now describing that you have integrated screening, assessment, and treatment that focuses on both. So what that pretty much says to me, Michelle, you may chime in here, is that we have a lot of folks that are doing integrated treatment right now.
Yes, yes. But interesting if you look on down how you may have to refer them to another program.
Yeah, yep. And so what we're going to be talking about today are also different ways of doing treatment, but also how the integrated care or the coordinated care between folks who provide mental health and substance abuse treatment services and supports actually work within a system of care. So thank you, Kay. So you'll see here some of the statistics are dated. You'll see the numbers down here underneath. Some of them are dated. But they're also holding true according to the researchers in the field. And we're looking right now at youth between the ages of 12 and 20 and seeing that 90% of the drug use and associated problems begin during this age. Many of us are also seeing the drug use beginning at the age of as young as 9. One reason we are seeing problems begin is because the majority of the youth are minors and they get caught drinking or having problems in school or staying out late, and they get into more trouble more quickly than adults would. So that's one of the concerns that people have when they start looking at these numbers. Only 1 in 19 of our youth actually receive the needed treatment. Depending on the study and the population, researchers have found that anywhere between 50 and 90% of our youth with substance use disorders also have mental health disorders. And you know this, I'm sure, as well in your own practices. Our youth who become involved with the juvenile justice system are more likely to have a substance abuse problem than those in the general population. This could be another chicken and the egg question. Are youth in the juvenile justice system more likely to have a problem, or are they the youth with a substance abuse problem that were caught? We are lucky now that we actually have some longitudinal studies that can help guide our practice within our system of care. For instance, we know that when we do assessments that the assessments need to be very concrete, that they need to ask very specific questions. Youth don't normally volunteer information if you ask general questions like, are you using drugs? The youth who may be smoking weed thinks to themselves, what's the definition of use? Are they talking every day? No, I don't. Are they talking about using a needle? Nope, don't. How about heroin? Never used it. Pills? Nope, not me. So their answer would be, nope, counselor, I don't use drugs. Most kids won't even consider marijuana and alcohol a drug when you talk to them. We talked about how our youth may have multiple mental health and substance abuse diagnoses. With youth, we've learned that they often have lapses because they don't really fit into the traditional category or just definition of relapse. They oftentimes do not meet the diagnostic criteria for addiction, but they definitely have a diagnosis of a substance use disorder. We've also learned through these longitudinal studies that adult substance abuse screening, assessment, treatment, and continuing care tools and models are not effective with youth. Successful outcomes for our youth most often means providing supportive interventions for our youth across their life domains and across the agencies and entities that they're involved with. This is the slide, and also the next two slides are borrowed from Michael Dennis from Chestnut. He has one of the largest, if not the largest, databases possibly even in the world regarding substance abuse and co-occurring disorders. His slides have an amazing amount of information on them. We were talking about them the other day. And so you'll probably see things here that we've not even seen yet because there's so much information here and there's so many ways to slice and dice these slides. But I'm going to walk you through the next couple slides. This slide lists common problems that youth may have along the left-hand side of the slide here. And along the bottom of the slide, you'll see the percentage of youth who are having this type of problem. The green line here indicates youth that have no or frequent substance use, and the orange line are youth that have weekly or more substance use. And it's pretty easy to read this slide. Youth that are using frequently are experiencing significantly more of these identified problems along here.
Kari, can I just interject for a minute, I think, if you'll go back to that slide? This kind of hits home early on when we did Reclaiming Futures, because we were seeing kids that had coming out of the juvenile justice system that were in the juvenile justice system for criminal charges, some type of charge, and we would go back into the clinic and note that they had been seen for mental health problems, but no one had ever caught the substance abuse problems until we started working with them. And once we started, through our Reclaiming Futures work, able to identify that the majority of our kids that we saw in our program had co-occurring issues, but JJ and mental health missed those. So it was important, to kind of start educating people to check, on both ends of it, what's the mental health and what's the substance abuse.
Excellent. Thank you, Michelle. This slide here is another one that was borrowed from Michael Dennis. It's similar to the last slide, but breaks the information down to a more discrete level of severity of substance use. So these are adolescents, different from the last one, from age 12 to 17. And you'll see the severity scale way at the bottom here of the slide, and a list of the different offenses or crimes listed right above that. And then on the left-hand side of the slide, you'll see that you'll see the percentages of youth participating in each one of these particular crimes. And the brown line indicates a dependence diagnosis, as you can see right here, which is the most severe diagnosis listed on this one. And consistently, this brown line, this dependency line, is higher in each one of the crime categories than the other levels of substance use. Youth who are dependent or addicted are significantly more likely to participate in the crime and violence than those on the other levels of use. And it's too bad we don't have time really to kind of slice and dice this and discuss the bulk of the information on these slides. But it is interesting that the dependence, abuse, and weekly alcohol, these three here, that those weigh as the top three in each category. And it's also interesting to note that the frequency of carrying weapons down here, each of which could be a conversation in and of itself here. So this slide is also looking at ages 12 to 17. It looks briefly at the impact in their lives of the severity of drug use here. Dependency, once again, wins out, these brown areas here. They're more likely to have arguments with their parents or their caregivers. They're more likely not to like school. They're more likely to have a low grade point average. And on this slide, there are actually three instances when the category of any drug or heavy alcohol use, which is this one here, actually goes higher than this other level here, which is different from the other slides, the weekly use. Another note here is that the percentages seem to level out when it comes to youth with co-occurring depression and with receiving any mental health treatment. So those two areas of the co-occurring, the lines really start coming together so that everyone is kind of having those problems of receiving treatment. And at least within the categories of major depression, it's not uncommon to be seen across the board. Michelle, you want to add anything there?
No, I just think again this reiterates the fact that what we're trained for often is what we see, what we look for.
Right.
And so if I'm a mental health person and I'm in a school setting and I see that this kid hates school and that they've gotten in trouble at school, I'm probably going to equate that to mental health issues and maybe not necessarily to the substance abuse issues.
Right.
And vice versa, so I think it just reiterates the point of co-occurring, because co-occurring isn't one primary and the other one secondary, but really truly that they both occur together. And I think looking at the major depression piece of this slide and any mental health treatment, kind of tells us the same thing, is that it's, again, that 50 to 90%, the 60%, we're going to see more mental health issues. Even if it's not just a diagnosis, we're going to see behavioral health issues out of these children, whatever the diagnosis is.
Right. Thanks. So this slide actually is talking more about the treatment system itself, the substance use disorder treatment itself. And these bullets primarily refer to residential treatment settings. But the fourth bullet down here talks about there's only 23% leaving higher levels of care that are transferred to outpatient continuing care, which is abysmal. It's frightening. It's why kids keep going in and out of the system. It's why kids get worse. And this is a 2012 SAMHSA slide, so it's fairly recent that kids stepping down from a higher level of care for substance use treatment rather rarely go into an outpatient continuing care program. And you can also see that these other bullets down here, when we're talking about staff turnover, staff education, the electronic healthcare record, all of those also could be just as well said about outpatient treatments. Okay, these are actually considerations here for us to take into account when working with these youth within our system of care. We all know that these youth have less control in their lives with adults. That's true within the traditional system of care when we're looking at kids with severe emotional disabilities. We also know that system of care work has been ever evolving and creative and ensuring improved and meaningful involvement with families and youth, and that most youth don't even recognize that they have a substance use problem. And it's really hard to convince kids to agree to work on a problem that they don't even think they have. Other considerations that we have here to take into account are that the needs are complex, they're varied within our youth. The multiple systems that that they're involved with and have different languages, particularly acronyms that they use. Also, there are different beliefs or philosophies with their different agencies or entities, and what they consider to be the best interventions or the best way to treat or interact with kids who have substance abuse problems, and also with their families. We talk about blame and shame a lot within the mental health world, and I think we could probably exponentially add that to families who have substance use disorders within their family. I'm going to pull up a quick survey here. I'm not going to talk about this much other than to say that this is a report that came out in 2009. Kay, could you pull up the survey number 5, please? I just wanted to get kind of a sense here of who's seen this document. I don't know if you can see the document with the survey, but So it's looking like most people haven't seen the document. Some of the people know about the document, and it looks like one at least has read the document. Great. Then I won't feel like I'm being real redundant here. Thank you, Kay. So, in this document here, what we're talking about is there were a small group of folks from various perspectives, including those from system of care communities, that were pulled together in November of 2008 to discuss developing a system of care for youth with substance use disorders. And you can see the two goals were essentially to determine the essential elements to implement this kind of model, this kind of system of care, and also to build bridges between substance abuse and mental health fields and other critical entities or agencies in order to improve the integrated care for kids. This probably sounds really, really familiar to you system of care folks out there. And I put this slide in here. I know the system of care folks there are really familiar with this in the next slide. But I thought it was really important to put in here because this is something that that group, that varied group that came together in 2008 also went through. So they went through and looked at the work of Strahl and Friedman and the groundbreaking work, actually, that articulated the values and principles of a comprehensive system of care. And later there was a national evaluation done of 126 system of care sites, and they found that youth in those system of care, including those with co-occurring mental health and substance use disorders, achieved positive outcomes in a number of domains. Their grades improved, school attendance improved, youth involvement with juvenile justice actually decreased, the level of overall emotional and behavioral problems declined significantly, and suicide attempts declined. So they discuss that the lessons learned about the wraparound process, which we use within the system of care, have relevance for a recovery-oriented model of care, and that the positive youth development field has also so much to contribute to this recovery system of care. This is all of the things back in 2008 that this small group, this consultative group, was discussing. They looked at this, and I put this in here, and hopefully we'll have a little bit of time to go back and look at this again within the context of co-occurring. But this is an updated version of what they looked at with the core values and the guiding principles that you all are very familiar, so I'm not going to spend time on this right now. So the following information that I'm going to be presenting to you is kind of results of the work that that group did in November of 2008. They worked a lot and honed it down to 4 different areas. One of the areas was values and principles. Another one, services and supports. Then we'll look at infrastructure necessary for developing this kind of system of care, and then outcomes at the individual, family, and service system level. Starting off here with the values and principles, and I want you to kind of keep this in mind as I'm kind of going through this, what this means within your system of care or within your site that you're providing services to kids, and particularly with kids with substance use or co-occurring disorders. The values and principles that really came to light, basically they included developing a broader understanding of family and their involvement. They talked about having services and supports that were developmentally appropriate, that were strength-based, and that promoted resiliency skills of youth. And they acknowledged that getting better, quote unquote, getting better is not linear. In other words, there are times that youth get better, and there are times that youth get worse, and life just happens. And I believe this is not different at all from what we talk about with youth with a mental health disorder diagnosis. The second area that they talk about here are services and supports within the system of care. And here they've identified the importance of ensuring ongoing family involvement. You'll see this all throughout. So I think it was one of the, in 2000, I think back to 2008, it was a time where that real push for system of care sites to really figure out not only how to have a quote-unquote token parent or a token youth at the table, but to have family and youth who had meaningful involvement at all levels. And so you'll see this throughout this conversation that they had. So the second identified area is services and supports. They identified the importance of the family involvement and providing linkages to other resources and supports, as well as addressing needs across their life domains, the youth's life domains, and providing appropriate therapeutic interventions, which includes developmentally appropriate. And they also recognize the need to foster social connectiveness, which was also a big thing for kids with emotional disabilities that we talked about. The third area that they talked about was necessary infrastructure elements. And once again, this is a summation. We definitely want you to take a look at the whole document there, but the summation of this, they included the participation of families once again, and that the families needed to be involved at the design level as well as the policy level. They included that they discussed the need of policy changes at all levels and looking at ways to be creative and be collaborative with funding. I think funding is still an issue that we're dealing with. In many states, some have, I think, tackled it quite well, but by and large, we're still dealing with that issue. They felt that it was important to delve more deeply into the need for leadership and what that leadership could look like. And they also discussed how it was important to address accountability. And they weren't just talking about accountability for the kids and the families, but they were talking about the accountabilities of other agencies and entities within a system of care. And then their final category was outcomes. And when they talked about outcomes for youth, they discussed the need for developing a way to address their lack of social connectedness, and also discovering positive ways for the youth to be involved in their community and ways that they could give back to their community, and therefore building the strengths-based assets. And when they were talking about assets, this is another, you can kind of date this with the 2008, but when they were talking about assets, they were also talking more about the community assets, building your community to have the strengths and the ability to support youth in a positive way, and therefore creating assets within each of the youth. They also discussed the need to develop ways to encourage self-sufficiency for youth. When looking at the outcomes for the system, they identified things like developing supports for the family once again, and this time they mentioned including siblings, and ensuring that the system of care had no wrong doors when trying to get access to services, which again, as we most states move into managed care, it is yet another topic that keeps coming up even to this day. They identified a number of challenges and opportunities when they were kind of summing up what they've learned over those 2 days in 2008. The participants identified both of those, and the challenges that they identified included a lack of shared language, acronyms, a lack of common vision amongst the system partners, and that included the families and youth. That there was a stigma that exists, and we're still just now with the recent discussion about, once again, about suicide prevention and the impact of stigma. They talked about the disparities that exist and a lack of competency. They talk about the lack of family and youth involvement and the lack of integrated system supports, including robust funding sources. They talked about a lack of accountability with appropriate outcome measures, that we weren't measuring our outcomes, and so how did we really know what we were doing was working? They talked about an inadequate workforce and not enough of a workforce, and that the workforce that they did have, there was a lack of appropriate services and supports. They talked about a lack of coordination of care, case management, service coordination, team meetings, team planning. They talked about a need for more research, evaluation, and dissemination of evidence-based practices and best practices, and a need to address confidentiality issues, which really has been, I think, for a lot of the Reclaiming Future sites for decades now, has been an issue of dealing with the confidentiality of a treatment provider within a court system. So what can be shared, what can't be shared, what should be shared, what should not be shared, what legally can be shared and what can't be shared, those confidentiality issues. Although a lot of them have been taken care of as far as understanding what HIPAA meant, which in 2008 we struggled with even knowing what that meant. I think that the confidentiality issues still exist. And they also talked about a lack of statewide focus on adolescent substance abuse, that while there were areas that were providing substance abuse treatment, the infrastructure for those communities was poor at best, and because a lot of the infrastructure required the state to have the correct interventions, the correct supports in place in order to be successful. Michelle, is there anything you want to add to that?
Yeah, I was going to say, many of y'all may be sitting here nodding your head going, yeah, we're still dealing with all of that. And I would say, 2008, when you talk about a system change that's not so far away, that's still kind of, I think we're still in our infancy trying to make some changes. At least here in Kentucky, I can say, we're still dealing with a lot of those challenges. We've made some strides, but I think a lot of us will still, that these are things that we see now, and these are things that we still are working toward, and so it's an opportunity as well as a challenge.
Absolutely. Absolutely. And that's one of the things that you'll read in this report also, is that they had a really lengthy discussion about how, and they also recognized that they had more challenges than they had opportunities listed here. But they also talked about how those challenges could very well be made into opportunities.
Yeah, and what we learn at the state level sometimes takes a while to filter down on those local levels. And so not only are you dealing, we're learning at the state, and we're trying to change and train our workforce to do integrated treatment, but sometimes what's down in the local level, tend to be people who I've done it always this way, so this is the way I know and this is the way I do it, and it's a little harder to make some of those changes, and even philosophical changes is a little harder when you get on that front line piece.
Yep. And I would also say vice versa, because we've had some conversations about how policies seem to lag sometimes 2 or 3 or 4 years behind where the treatment field is going. So sometimes the state and federal level is even slower adaptation, particularly on the policy level, which means funding and ways to be able to provide services and supports. So the next part of this here is looking at the opportunities. And the opportunities here, what we're talking about is a growing awareness. Again, we're talking about 2008 with this, of a high rate of co-occurring disorder. and an increase in the pockets of excellence where these examples of promising practices are being used in communities across the country. And once again, 2008, we have more than pockets now, but still, it's not consistently across the United States. There are opportunities that they discovered with assist of funding of services. There's formal and informal resources that are being identified within the communities. And there's an emerging technology, and once again, 2008, that could be used to improve outreach and connection to youth. So even then, and I know that there's recent conversations even now about how do we use technology. We all know that youth are so incredibly technology savvy, and I will speak for myself, at least I am not even close to being as technology savvy as most of the youth that I come in contact with. So how does our system really embrace and harness the emerging technology in order to have better outreach for youth?
And Kari, this is just your 20-minute heads up.
Thank you, thank you. So here the group was talking about looking at where they had consistency and consensus on everything. And even giving the diverse spectrum of participants that they had within this group, the group demonstrated a really strong consensus and consistency on the values and principles of the recovery-oriented system of care, the services and supports essential to such a system, and also the infrastructure that's necessary in order to support recovery-oriented systems of care nationwide across the United States. And there was a strong support for family involvement at every level, from policy to direct service. And there was also consensus that the values and principles, and this is really important for you system of care folks out there who haven't gotten to the point of having a really strong integrated treatment, the values and principles that these folks identified for this recovery system of care aligned with those articulated by Sterling and Freeman, and provided a basis for common ground between the mental health and substance abuse fields. So during those 2 days, this group of folks coming from very different backgrounds and belief systems came together around these core values and these guiding principles in order to say, you know what, this would work just as well for kids with substance use disorders as it does for kids with mental health disorders. The consensus also underscored the importance of creating holistic systems of care across the youth-serving agencies. And these agencies included substance abuse, mental health, Medicaid, child welfare, juvenile justice and education, a lot of the folks that are on the call today. While the primary focus of the meeting was on design and essential elements, the need for the integration became a critical theme that goes throughout this document. It became really clear that ultimately the service systems must be integrated to realize a well-functioning, recovery-oriented system of care. The integration has to occur. Participants stressed the importance of integrating systems at all levels, federal, state, and community, as well as integrating the individualized services and supports for each youth that they serve, and that it be provided in a comprehensive, coordinated and holistic care setting. They also said that the design had to meet the needs of youth and the family in a flexible and integrated, collaborative, and outcome-focused way. Once again, realizing that importance of youth and family. And to make these system changes, and this is in their words, it required a new mindset and transformation of systems and services that would focus not on problems, but rather on engendering hope, optimism, and the fulfillment of each young person's potential. So they went to a really strength-based place. So when we're looking at these aha moments that these folks back in 2008 had, and their recommendations, and what we now know, we've learned that when we develop strategies for better implementation of services and supports within a system of care, co-occurring disorders must be addressed in order to achieve the kinds of outcomes that we want for the youth and that we all strive for. So as we move forward to either develop or integrate or coordinate or enhance our system of cares, your system of care, that includes services and supports for kids with substance use disorders, here are a few thoughts to ask your implementation team or your change team or your interagency council or your community members, however you function within your community. And some of the questions that you want to ask include things like, does your system of care community serve your youth with substance use disorders? Right now, at this time, do they serve those kids? Are your services and supports for adolescent mental health and substance abuse separated into specialty areas? Are there specialty providers that you use, one for substance abuse, another for mental health? Are those providers guided by a system of care values and principles? Do you know if they are guided by those principles? Do you have data that can help you better understand or help you better describe or better identify the mental health and substance abuse needs of the youth within your communities? Is funding of substance abuse or co-occurring treatment services and supports an area of great concern within your agency or your system or your community? And other reflections are things like, are your substance abuse treatment services and supports developmentally appropriate? Are the tools you're using able to red flag or uncover possible substance use problems? Are you using evidence-based tools and practices? And if so, how are those practices being monitored for fidelity? How do you know that they're being done correctly and that you're getting the results that you expect? So I'm just going to really briefly go through this different methods of co-occurring treatment delivery. And I say this because when we're taking a look at this, there's really three levels that we look at, and based on how you answered in the beginning, there's kind of a no-brainer on this one. So the first one is called sequential treatment. And in sequential treatment, the substance abuse treatment is often followed by the mental health treatment. In other words, we can't treat the mental health issues until they're no longer using substances. The problem is that we lose youth when we're practicing this type of treatment. If we don't address the whole youth, we often can't engage them in any type of treatment. In other words, they come to us with both mental health and substance abuse issues. If we just say we're going to treat certain symptoms and not others, we often can't engage them in any kind of treatment. Another one is called parallel. And parallel care happens when the substance abuse treatment and the mental health treatment happen within the same time frame. But it is mostly provided by multiple providers, so there's different clinicians or counselors, and oftentimes they're in different locations. The youth and families are often overwhelmed with this type of service delivery because oftentimes they have to go to different locations or get to know different people or tell their stories multiple times. Treatment and supports are rarely coordinated in an effective fashion when they're done like this, when there's multiple providers. There are different agency programs, billing requirements, documentation requirements and expectations, and those kinds of differences in the bureaucracy or the administration of these services often cause conflict amongst providers and agencies, let alone the conflict between providers and youth and families. And so here we have the integrated treatment. And integrated treatment also happens during the same time frame, but the treatment happens within the same session or within the same context of time. And most often with the same clinician or counselor, the staff have to be or become comfortable in screening, assessing, treating, and supporting youth with both mental health and substance use disorders. This is not as difficult as it may seem, since our youth are already coming to us with co-occurring disorders, whether we diagnose and treat them as such or not. Our youth don't come in nice, neat little packages according to what our skill levels are. And so most of the time when kids are coming to us with co-occurring disorders, even if you identify yourself as a mental health counselor, you're also providing interventions for their substance use and vice versa. Michelle, do you have anything to say about that one?
Yeah. I was actually thinking of a couple of things. As we were going through the slides, I can remember very clearly a psychiatrist telling me that they couldn't treat a child's depression until she had been sober for 6 months. And so one of the things, we tend to, part of your slides was saying, is that we have to do integrated care. And coming from both areas, mental health and substance abuse, sometimes in the mental health field we think substance abuse does something kind of differently. And as you said, to reiterate, it's not all that different, that when we're treating that child and providing services and supports for that child, we really are providing services and supports for both issues when that child is there. And that it's important because when we think about, again, co-occurring, meaning that it occurs at the same time, treatment has to occur for both at the same time. You can't talk about depression without talking about how the substance abuse issues may influence the depression, but you can't talk about the substance abuse issues without talking about how the depression may influence the substance abuse issues. So it's important to talk about both, again, integrated.
Right. And once again, the chicken and the egg.
Yeah.
So with this integrated model that we're talking about, we're actually saying that we don't have to identify a primary diagnosis. Once again, the chicken and the egg thing, except for billing. And I know you're always saying that out there for billing.
Billing and coding, but we have to code it.
Billing and coding, yes, we do. But for treatment, for addressing the youth, you don't really have to know which is primary. And oftentimes can't know which is primary. We don't have to establish what caused what. We don't have to decide if there's a causal effect of one or the other. We may be able to understand it better as we go through treatment with the youth and the family, but it's not something that we have to discern before we get started. And we understand that both are needed, both need to have simultaneous treatment. To address one without the other is not a holistic manner of treatment. So an integrated model within a system of care looks like this. There is one competent treatment or service team or whatever you call that interagency group that recognizes and addresses all of the mental health and substance use disorder needs at the same time, during the same planning meetings, during coordinated interventions, and using effective communication to make sure that everyone is aware of what's happening and what's working and what's not. So a system of care that includes identification, it includes treatment and support and continuing care for youth with co-occurring disorders provides hope to better serve our youth. I'm going to open this up for questions. Cora, do we want to just have them raise their hand if there's a question that they have or a comment that they would like to make?
Yeah, I think if you are on the phone and you would like to raise your hand and ask the question over the phone, please do. Otherwise, please feel free to type any questions into the chat or Q&A.
So, how much time do we have here, Cora?
We have 5 minutes.
Oh, okay. So just so that we can maybe pull this together for you all, I'm gonna let you do this and see if we can pull some information together and have it available for you all. What I'm going to do is put up a slide of the values and principles, and you'll see that each one of them is numbered. And what I'd like you to do is in the chat line there, and if you're in a group, if you can just go ahead and put them in all together, that would be fine. Identify at least one and up to 3 of the values and principles there within the system of care that we've embraced that may be difficult or challenging for the substance use treatment providers to adopt and operationalize. It's one thing for them to say, yes, I believe in this, but actually operationalize, actually use this. So if you wouldn't mind, choose those 1 to 3 that you think might be more difficult for a substance use provider to actually implement, and put that into the chat line there. And you can see the corresponding numbers here. Just to let you know I'm still on the line. I hate the dead air.
I was trying to read, I'm sorry, this is Michelle. I was trying to read through some of these, and I was thinking, from the state level, and trying to think now, what would the substance abuse providers in the state of Kentucky have most difficulty with?
Yeah.
And knowing that what I see here in Kentucky is that, and I think it had to do a lot with billing issues, is the majority of children and youth services people, when they started to understand co-occurring and started to understand substance abuse, the children's services in the mental health field could serve youth with substance abuse, but we've had some more difficulty with the substance abuse field learning to serve children. And I think sometimes it's more, it has been because of billing. There's been another number of other issues, but I think for them to be able to be more developmentally appropriate, because notoriously in our state they've tended to be more adult focused, so they don't know how, even though we have evidence-based practices in the state for adolescent substance abuse treatment, the majority of that has been in the mental health arena. They've picked those up, and so our substance abuse providers haven't quite all gotten there yet to be able to do that.
Right.
The other piece of it, I think, is for them to be able to understand that team-based process, because sometimes, if we're looking for our substance abuse providers to serve our children, oftentimes we go to providers who are used to serving adults, and so they don't quite understand that wraparound process and that team-based. Now, if I stay in the mental health field and I stay over in children's services where they've, had the system of care philosophy and been working around on wraparound, 15, 20 years, it's not an issue.
Right.
So, it's that 8-year, 2008 where we're just starting to figure out the recovery-oriented system of care for children in the substance abuse realm, I think, and trying to pull those together and bring the field along. Because substance abuse treatment, evidence-based practice, the whole array, when you talk about adolescent substance abuse treatment, in my opinion, really is still in sort of its infancy, or at least in its, middle childhood now, because we've just grown, in understanding what we're doing and evidence-based assessments and evidence-based practices.
Yep. And Kara, are you able to get all of these written down, the responses?
I can, yeah.
That would be great. And I see that Mark made a comment here, too, about the ever-shrinking amount of adequate or non-robust funding. And I think that is probably another webinar, to be really honest with you, because I know that in Kentucky we've struggled with that ourselves, and most of my colleagues across the nation that I've talked with are also struggling with that in a time especially of managed care, and managed care looks very different in different states, that it's a real challenge for people to figure out how to fund these in an adequate way so that they can be provided with the kind of required fidelity that evidence-based practices hold forth, because some of that intervention is not really considered a billable kind of intervention there. So thank you, Mark, for those comments. And I think our time is up. Is that right, Cora?
It is. Thank you all for joining.
Yes. Thank you all so very much. And I think we also have, I think we also have our email available. I'm not sure where it's at, but we have our email available for you all. So if you have questions after this webinar, or have some other information that you would like to share with either Michelle or myself, please, there it is. Oh, there it is, sort of. Please feel free to contact us. And thank you all so much for participating. Okay, will this presentation be available for folks?
It actually will. Usually once we get everything, like all the reports from the actual webinar, we can send that to you with the recording as well.
Great, thank you.
So it'll have the whole, like, with you guys talking, it'll have everything.
Hi, great. Thanks all.
All right, was there anything else you ladies needed?
I don't think so.
Okay. All right, so I can end the session now if you'd like me to.
Okay, thank you.
All right, no problem.